Okay, thanks, Amro. Well, so we just heard how useful it is to perform a CTA on SVIN with a mobile stroke unit. There is still discussion about if all suspected patients should undergo, with a stroke, should undergo a CTA routinely. This is quite normal and available in the setting of a comprehensive stroke center. In spoke centers, in smaller centers, it might be more challenging. And on top of that, in order to perform a CTA, you need to think that this patient may be suffering a stroke. So somebody has to think that possibly this altered mental status is a stroke. So I was looking for information about the availability of CTA 24/7 in all centers. Of course, the situation changed probably substantially since 2012, but this publication, you can see that at that time, it was a minority of patients that were getting a CTA, maybe because it was not available at these smaller centers, or maybe because nobody thought that this patient needs a CTA, right? So coming back to the question about do all patients with a suspected stroke need a CTA? Of course, we have the pros in this controversy, which we all know. It helps us determining the presence of an occlusion and act faster and better. And there are some cons, of course, that can be overcome most of the times. But in my opinion, the most important or the most is that you need to think and that this patient might be suffering a stroke, and therefore you need to ask the technicians to do that. About the reliability of automated large vessel detection on CTAs, we learned yesterday, from Raul's presentation, that presently available softwares are very accurate with high sensitivity and specificity in determining LVO automatically on CTAs. And this is great because it helps reducing workflow times. So can we extract most of this information that we get from a CTA from a non-contrast CT? So we tend to think that advanced imaging is CT perfusion or imaging based on contrast. But in my opinion, probably soon we're going to substitute contrast by some kind of processing of the image in which you don't need even to think to administer contrast, and you don't need the hassles of contrast. So our hypothesis was to test if a machine learning algorithm designed to recognize patterns of large vessel occlusion without the need of contrast could accelerate and increase the identification on endovascular treatment candidates. And this could be especially helpful in the setting of community or spoke centers. So the methods were to acquire CT and CTA performed in patients with suspected acute large vessel occlusion or strokes, in which neuroradiologists draw manually the area of hypodensity and the area where the occlusion was determined. And they merged the non-contrast CT with the CTA in order to teach an algorithm that we called deep stroke to identify large vessel occlusions. So the methods were to analyze over 1,000 patients with suspected strokes within 6 hours from onset, who underwent both techniques, non-contrast CT and CTA, from 3 different stroke centers, and compare the distribution or the identification of large vessel occlusion with the ground truth, that would be the CTA, as compared to deep stroke. And On top of that, we also determined the accuracy when we added a few clinical information about the patients at the NIHs and the time from onset. And we call it Deep Stroke Plus. So this is the what you get, the analysis from deep stroke. It shows, of course, hemorrhage, the volume of the hemorrhage. And when you go to patients with ischemic stroke, the tool is able to identify or to predict where the large vessel occlusion is, where the clot is, and it gives a percentage of how confident is the system, saying that there is a clot there. And also it draws the area where there is an hypodensity that you will predict where this is the core, right? And here we can see on a video how we can scroll through the images, we can change the contrast, and if I could use but I cannot advance the video to that. Anyway, you get a picture of the concept. So here are the results. The ground truth confirmed that neuroradiologists confirmed a large vessel occlusion in 724 patients, of which in 616 deep stroke also identified and matched the diagnosis of large vessel occlusion. On top of that, if we use the Deep Stroke Plus, in which we also included some minor clinical information, the number of identifications of occlusion increased to 633, meaning that here you can see the distribution. So from the 724 patients with a non-contrast CT, you could identify a deep stroke, could identify most of them with a relatively small percentage of false positive identifications. So, as compared to other automated softwares that detect large vessel occlusion on CTAs, the results are the area under the curve is really comparable. And in conclusion, that we can say that deep stroke identified large vessel occlusions with no need of contrast CT. It can reduce the needs to perform CTA and can generate alarms, increasing the efficiency in transferring patients and identification of patients. And of course, it will improve its accuracy as we teach the system more with more patients. So basically, this would be the setting in which it could be used. So if you apply a screening to all non-contrast CT in a territory, you will have alarms of about cases in which there could be a suspected large vessel occlusion or a pretty confirmed large vessel occlusion, I'm pretty sure, with high confidence, and this can generate an alert and so you can tell that center that in that or that case, you should either just transfer the patient immediately or consider doing a CTA to confirm the occlusion. And you can, of course, do that to all non-contrast CT, and nobody has to think that this patient may be suffering a stroke. So thanks for your attention.